Hello everyone, it's good to have you all here. Today we are going to handle a new topic, and that is what we call cardiac arrhythmias. So cardiac arrhythmias is a cardiovascular condition that affects the rhythm, the normal rhythm of the heart, the normal conducting system of the heart. So when we look at how does the normal system conduct, we need to appreciate the presence of the conducting system right from the pacemaker, and our pacemaker is the atrial nerve or node, not nerve, excuse me. And then we have the AV node, and then we have our bundles of his, and then we have Purkinje fibers, or first we shall have the Purkinje bundles, and then Purkinje fibers, yeah. So if there is a problem with the pacemaker, meaning something else will set the pace, and that something else that will set the pace can either be the atrium itself or the ventricles. Or we may find that instead of the SA node acting as a pacemaker, we shall have a new pacemaker as the AV node. And as a result, we find that there is going to be a problem, okay? Because it's not the normal thing or the usual thing that is sending impulses to a specific to bring about depolarization, sending of action potential, and bringing about contraction of the heart. Yeah. So let us look at much about it. That's briefly about the physiology of how the cardiac arrhythmias may come about. So we see that the ionic basis of the normal cardiac action potential, we need to appreciate what do we have outside the membrane and what do we have inside the membrane. So we can see that outside the membrane, we have sodium ions more, and that membrane, because of the presence of sodium ions, is generally positive outside. Then inside we have potassium ions more. So when potassium ions are more, we see that potassium inside the cell is always negative. So when an impulse is sent, there should be degeneration. This degeneration is brought about, or depolarization is when the threshold has been reached. So when a threshold is reached, we find that the first sodium channels are going to open. When the sodium ions open, we shall reach a specific threshold. So when we reach a specific threshold, maybe negative 50 millivolts, we shall find shooting, like sodium ions are now going to rush in. When they rush in, we shall have a change in the membrane, whereby we shall have sodium rushing in, and then when sodium rushes in, inside becomes more positive. When inside becomes more positive, there shall be depolarization. When depolarization has taken place, we find that we need to restore back the membrane to normal, and we shall have our potassium ions opening. So when potassium ions open, sodium is rushed out. So when you look at the cardiac system, that can be a typical generation of action potential at the pacemaker or the senior atrial node. But we are also going to appreciate at the muscle. So when there is a muscle, or at the ventricles, that is the muscle in the atrium or muscles in the ventricles, we know that the muscle that we find in the heart is what we call the myocardium. Yeah. So we also experience other channels, that is the calcium sodium channels are present in the muscle. That's why we have our calcium sodium channels here, and then the potassium channels present. So our generation at the SA node, like I was telling you, the sodium ions have to rush in, and then after that there should be a depolarization which allows potassium ions to also rush in, and we expect to find this specific sketch of the diagram, whereby this represents our threshold. So we see that at a resting membrane potential, where we have sodium ions outside and potassium ions inside, the membrane outside is positive, the membrane inside is negative. When sodium ions open, or when a threshold is reached, we find that there is opening of sodium ions. Those sodium ions bring about depolarization. This is a depolarization phase. And then we shall have our potassium ions opening to allow potassium to rush out in order to balance. Yeah. So when that happens, we shall have a depolarization, and we shall have depolarization and back to the resting membrane potential. So that's what happens. But if maybe at the AV node or at the muscle, it will involve the calcium and sodium channels. And we are going to appreciate that the graph is quite different when calcium channels are involved. Okay, so this is how our graph will look like. We see that this is at what we call phase 4. Phase 4 is our resting membrane potential. Okay, so at our resting membrane potential, we see that the membrane is at rest, whereby outside is positive, inside is negative. But we shall have our sodium channels entering inside. When sodium channels enter inside, we are going to have this sharp depolarization. So when this sharp depolarization takes place, we shall have what we call a brief entry of potassium, or opening of potassium. When that happens, we shall experience this number 2, which shows a slight polarization. Yeah. So, but as a result of presence of sodium calcium channels, we see that calcium channels decide to open. When they open, they rush into the cell. So when they rush inside, they bring about this phase 3. Yeah. So it means that they have rushed inside, so they bring about a prolonged, or it brings about a plateau or prolonged action potential. So this other phase 3 is brought about as a result of sodium and potassium channels opening. Then after that is happened, we shall have the potassium channels now opening. When potassium channels opening, we shall have depolarization. After depolarization, we shall have it going back to the resting membrane potential, and another one is generated just like that. So if there is a problem with sodium channels, then the rhythm is going to be different. If there's a problem with the conduction or opening of calcium sodium channels, meaning there is also going to be a disruption. Yeah. So we see that cardiac dysrhythmia or arrhythmias is when there is a disorder in the cardiac rhythm, just like what we have seen, or the stages that would lead to conduction of the rhythm. So how does it occur? We see that it can be disorder of impulse generation. Like I said in when we're starting, maybe instead of the SA node generating the impulses, is now the IV node in charge of the pace. So it affects disorder of impulse conduction. When impulses are not conducted right, it can bring about arrhythmias. We can also have disorders of both generations and then conduction, giving us this condition called arrhythmias. So disorder of impulse generation, when the impulse is like when there is a problem with how impulses are generated. We see that it is a most common problem when there is a development from a ectopic force or focus. You find that there are other things in the body that bring about contraction. For example, we can have the parasympathetic action. It is coming from outside. It is not within the what? The heart. But the SA node is within the heart. So you find that the sympathetic system affects the SA node. And that impulse is coming from outside. That information is coming from outside. So what happens? It will make the SA node to pump faster, or to it will increase the action. When the action is increased, the rate at which impulses are going to be sent the SA node are going to be fast. When that happens, we shall have fast contraction. And when that's happened, there will be increased cardiac output. When cardiac output is increased, you're finding that the body is supplied with a much volume of blood. Yeah. So what are some of the ectopic foci or focus, all those things that what does it focus on? It may damage the cardiac muscle, because if the external force is coming and is affecting, it can affect the rate at which the muscle is contracting. The muscle is forced to contract at a higher rate. So once there is damage of a cardiac muscle, that condition is what we call myocardial infarction. There are also other drugs that may affect the action of the heart. For example, the anesthetics can affect, and they have given us some of the examples of those anesthetics. We also have metabolic disturbance, for example, in hyperthyroidism. Hyperthyroidism is when there is increased action of the thyroid hormone or the thyroid gland. So when there is increased action of the thyroid gland, it brings about increase in growth, and it may bring about increased calcium concentration in the body. And we know that calcium is required for muscle contraction to take place. So when calcium is much, we find that there will be increased contraction taking place. Emotion and excitement. Some emotions, maybe you're sad, it can affect the rate at which catecholamines are released. Okay, so catecholamines are neurotransmitters that aid the peripheral nervous system action. And you may find that as a result, they will increase the cyclic AMP. When cyclic AMP is increased, we find that it will increase the release of calcium. Once the release of calcium is increased, you'll find that there will be increased contraction. Yeah, there will be increased contraction of the muscle, and it brings about these arrhythmias. So some of the arrhythmias that you may have, we have the supraventricular arrhythmias. You can have the atrial fibrillations, you can have the ventricular fibrillations, you can have the flutters. So those are some of the arrhythmias or examples, just like how they are listed here, and what could be the causes or what could bring them. So you can appreciate the fact that they are all listed here. Ventricular, so there are so many. What are the disorders of impulse conduction? When the impulse has been affected, we can have issues of heart block, and it happens mostly at the AV node and the band of His. So you find that the band of His fails to transmit this information to the Purkinje fibers. When that happens, we are going to find that the ventricles are going to fail to contract. When ventricles fail to contract, we shall have less blood moving out or even no blood, and that is very dangerous. So some of the causes that may bring about this block, it can be ischemia, reduced blood flow in that specific area, or compression of the node or bundles of His, and then we shall have inflammation of that area or extreme stimulation of the heart. Okay. So there can be very many degrees of heart block. You can have first degree heart block, you can have second degree heart block or block, and then third degree block. And all of them are described and explained here. So what could that result? You find that slower than normal ventricular rate contraction can take place, and then you find that the treatment may need us to use or to initiate the artificial pacemaker to enable the management. How does re-entry of arrhythmias take place? You see that it occurs due to the presence of the cardiac muscle of abnormal conduction pathways. Okay, so we have looked at the different types of arrhythmias. We say that we can have the flutters, you can have the fibrillations, you can have the supraventricular contractions, you can even have the paroxysmal. Yeah. So This all can like reoccur, rehappen. It may not happen once. And there are some things that would trigger their rehappening. If the myocardium is damaged, if the heart muscle is damaged, you find that there is nothing that's in charge of contraction. And once that happens, the rhythm is always going to be affected. The rhythm will always be. So, some of the things that may bring about the damage of the heart muscle ischemia, like little blood being supplied to the muscle cells. So when little blood is supplied to the muscle cells, you find that the muscle is not going to have enough nutrients, will not have enough oxygen, will not have enough ATP, will not have enough calcium to be in position to perform its function. There are also other drugs that may affect, for example, the beta agonists. The digoxin, those are cardiac glycosides, which inhibit secretion of calcium or inhibit or bind to the calcium channels. So you find that they may also affect the rhythm. Okay, so the normal heart, we expect it to operate like this. In your free time, you can pause and go through the slide. So if there is blockage, you find that the flow is interrupted. It can be the left hand side, it can be on the right hand side that has been affected. So blood is forced to find mechanisms to manage or to enable it do its function. So after you have understood the physiology of cardiac arrhythmias, it's good for us to appreciate the drugs that we use for the different conditions that affect the rhythm of the heart. So they are classified basically based on the graph that we looked earlier on. That is the graph on how action potential is generated. So we can have those that may inhibit the fast sodium channels. We may have those that will block the slow calcium sodium channels. We may have those that will work on the potassium channels and so on. Okay. So those that would inhibit the sodium channels may lead to either slowing of conduction or may increase the refractory what? Period. Yeah. So they can be classified in two classes, class 1, class 2, class 3, and class 4. Or you can call them groups. In this specific lecture, we classified them in two groups. So we have group 1A, group 1B, group 1C. We have group 2, which is still the same as class 2, class 3, and class 4. So if you're reading in a textbook and you're finding class 1, class 2, it is all the same as what we are trying to explain or describe here. So we see that group 1A are suitable for ventricular and the supraventricular arrhythmias. Excuse me, sorry for that. We have drugs such as quinidine, sorry for that, quinidine, we have procainamide are some of the drugs that you use. So when you look at it, we are focusing on blocking the sodium channels at this specific rate. When we block the sodium channels, we see that there is going to be a rise in the threshold and excitement, and it will delay. It may delay the depolarization and the rest. So these are the drugs that we use. Class 2B, class 1B, we have examples of lignocaine, phenytoin, and some of them. We are also focusing on shortening the duration of action potential, and it is effective on the refractory period. These examples, as we can see them, in your free time, you can pause and go through that. Then group 1C, we see that examples have been given to us here. We have the flecainamide and then econamide, and we see that they are in charge of slowing the intracardiac conduction. So it widens the QRS complex, which enables to bring about stabilization of the phase, that contraction phase. So let's look at group 2. Group 2 or class 2 drugs that we use in management of cardiac arrhythmias, we call them beta adrenoceptor antagonists or beta blockers. Okay, so we can appreciate that the different beta blockers that we have the propranolol, we have all of them end with the term lol. You should put it at the back of your mind. So we know that it inhibits the binding of the neurotransmitter to these receptors, and once that happens, it is going to reduce the rate at which contraction takes place at that specific area. So you find that it enables to reduce the automaticity, okay, of our pacemaker. And we said our pacemaker is the sinoatrial node. Then we also see that it increases effective refractory period and then decreases conduction. So we are still on examples of group 2. We are now going to group 3. We are trying to run fast, but you can pause this video to always condense and appreciate that specific slide that we have just finished. Okay, so we have group 3 derived drugs. So group 3 derived drugs work on the potassium channels, so they end up blocking potassium channels, and our goal for blocking the potassium channels, we want to prolong the duration, we want to prolong the plateau, we want to prolong the duration of a cardiac action potential, and by doing so we see that we are achieving at lengthening the refractive period. So some of the drugs that we have in that class are here. We see that we have sorry about the sound, the phone is getting full. So lateral is a class that you can have, and you can appreciate it here. We have group 4 as our last class, and group 4 handles calcium channel blockers. The PC is shutting down. I think I'll stop here. Sorry for this. We are going to continue it.